Hello, and welcome to episode 3 of the Joey Matina podcast. Today, I'm joined by Dr. Alexander Weber. Alex is a specialist in the field of orthopedic surgery and sports medicine at USC. His practice has an emphasis on arthroscopic surgery of the shoulder, elbow, hip, and knee. He's also specialized training in all types of shoulder replacement. He has research and clinical interests in the treatment of the athlete's hip and biologic solutions to cartilage restoration. He's lectured nationally and internationally on hip arthroscopy for the treatment of femoroacetabular impingement and cartilage preservation and restoration of the knee, and has authored scientific articles and book chapters that advance the clinical practice of orthopedics and sports medicine. Alex is also a team ortho for the LA Kings hockey team. That's where we met. Along with another doc, and then he heads the orthopedics for football team of USC, and also basketball. That's a joint thing you do, right, Doc?
Yeah, one of my partners is the head for football, and I kind of take the head for basketball, and then I help him with football as well.
Amazing. You're a busy guy, man. You got all the sport. You got hockey's going on right now. You've got basketball started, and how the football team how they doing, or how'd they do?
Football was a little bit down this year, but we still have our bowl game right after Christmas in San Diego.
Beautiful. Awesome. Well, Alex, man, welcome to the show.
Thank you. Thanks for having me.
It's great to have you on. I can't wait for this. I know you're a wealth of knowledge, and I just for the audience wanted to ask you first how you got into orthopedics.
Yeah. So for me, it was always sports medicine was the thing for me. I never really wavered about what in orthopedics I wanted to do. And that was in large part because growing up, I was an athlete, like most of the people who get into sports medicine, and played a lot of volleyball, and grew up in upstate New York, but played on the high performance team, which meant a trip out to, at that time, Colorado Springs, the Olympic Training Center. And all the teams that go out there get assigned an athletic trainer. And ours was kind of a motherly lady who allowed us to come check out the facilities they had for athletic medicine there, and just fell in love with it. She said, go check out what orthopedic surgery looks like. So when I got home, started shadowing a local orthopedic surgeon, sports medicine specialist, and that was in high school, and the rest is kind of history. I kind of went to college, medical school, knowing exactly what I wanted to do, which was kind of nice.
That's amazing. So you were like, this is it. I'm going straight through. And it was orthopedics from the start. You weren't like, oh, let me see, maybe dermatology. Amazing.
Yeah, no, it was straight orthopedic sports medicine. So right from the get-go.
Amazing. And nowadays you specialize in arthroscopic type surgeries, correct?
Yeah, absolutely. Go ahead.
And you do, shoulders, elbows, hips, and knees. Are those your specialty?
Yeah, so I would say I'm a little old school. I think a lot of docs now, especially orthopedic surgeons, want to do just one surgery or have one joint that they focus on. I've really found it kind of compelling and fascinating to stay very relevant in all of the major joints of kind of sports medicine. And I think that in part is because of being a team physician. When we're in the training room seeing athletes in the evening, or as you know, after a hockey game, it can be anything. It can be, my big toe hurts, or it can be my neck hurts, or it could be my shoulder hurts. And you have to be up and current on all of those things to be a successful and I think a really good team physician. And so for me, it's kind of translated into my practice as well. And so I do a pretty even split: shoulder, elbow, hip, and knee.
Gotcha. And can you give us an idea of what arthroscopic surgery is compared to a traditional surgery?
Sure. So traditionally, most surgeries were done through incisions, and still some are. So, shoulder replacement, hip replacement, knee replacement, those are all done through larger incisions. Arthroscopic surgery is typically to repair ligaments or tendons, muscles, cartilage or meniscus in the knee, and it's done through a camera. So we make small incisions, tiny. I consider them like poke holes almost, and we're able to put cameras and instruments through those small pokes. We use water during the surgery to kind of insufflate or increase the space of the joint so that we can see and work without bumping into the joint structures. And the surgery is done in a very minimally invasive fashion.
Mm. And is that you chose that method because you view that as a superior way of doing things?
I think that method has been shown to be the superior way of doing things for quite some time before I was in the field. But arthroscopic surgery really has become the state of the art for anyone who's in the sports medicine world. So if it's fixing rotator cuffs or labrums in the shoulder, if it's fixing the meniscus or ACLs in the knee, the standard of care now is to do those surgeries in an arthroscopic fashion.
And this may be an obvious question, but just to be clear, and that's largely because of the extent of damage that a larger incision would have created, correct? You want to disturb it as least as little as possible.
Absolutely. Exactly, Joey. So in order to speed recovery, speed healing, get patients back into the activities they want to do as fast as possible, we know that doing the least invasive surgery is best. So the camera and arthroscopic surgery has allowed us to do that.
Yeah. Are you personally using any robots with your surgeries, or is it just,
It's a good question. So robotic hip and knee replacement has become very popular recently. It hasn't quite made its way into the sports medicine world yet, but it's coming. I think probably more so than robotic sports medicine surgery, what we're going to see is more navigated surgery. So robotics implies that you have an instrument or device that is helping you do the surgery in the sense that it's actually manually or robotically doing something within the surgery. Navigation is probably what's coming into the arthroscopic or the sports medicine world sooner, which is where we are still doing the surgery, but with the assistance of a computer basically telling us this is where to drill that hole, this is where to stitch that ligament, etc. So I think that's on the forefront.
Wow, that's fascinating. I mean, that's bringing technology to a whole new level.
Absolutely.
I mean, amazing. Let's start with the shoulder. We'll kind of work our way down. Shoulder's obviously a very common injury. And you do the teams, but you also have a general practice, right, where you see general population?
Absolutely. Yeah.
Yeah. And so, all right, starting with the shoulder, let's say rotator cuff tears.
Yeah.
I see a lot of these in my practice, and I've read some research, but I would love to hear from someone who's more in that field. People ask me all the time, should I have surgery? How long should I wait? What clinically do you look for when you're deciding and trying to recommend, or not trying to, but if you recommend surgery?
Yeah, great question. So rotator cuff tears are not one size fits all. And in fact, we grade them based on the size of the tear. But I think for anyone who comes to me for the first time with an MRI proven rotator cuff tear, our data in the orthopedic world says it's worth trying at least 6 weeks of physical therapy. So if someone comes to me for the first time with a rotator cuff tear and they haven't had any treatment so far, they're getting 6 weeks of physical therapy. And then they're going to come back in 6 weeks. And if they're somewhat better, they're probably going to get another 6 weeks of physical therapy. If they're no better, we're probably going to have a conversation about fixing their rotator cuff. I think the plug I would put in here is recently we've gone away from giving these patients cortisone injections. Or where does cortisone kind of fall into my algorithm for treating these? It's kind of out of the algorithm, quite honestly, because there's good data now that if you have a cortisone injection prior to your rotator cuff repair, your chances of healing are much less than if you've never had a cortisone injection. So one of the probably, I would say the only study I've ever done, which is worth anything in this world, is a study that we did looking at this exact topic. And we used the Medicare database. So we were able to look at thousands of patients. We age and body mass index stratified 20,000 patients who had had a rotator cuff repair with a cortisone injection prior, and 20,000 patients that had the same age, body mass index, comorbidities, smoking status, etc., that never had a cortisone injection. And what we found is the re-tear rates, the reoperation rates were much higher if you had a cortisone injection prior to your rotator cuff repair, especially if you had that cortisone injection within 3 months. So that's really fallen out of favor, at least in my practice. There's probably a lot of people in LA who are still giving injections to people with cortisone or to people with rotator cuff tears. But I think really it's physical therapy. If you improve, a little more physical therapy. If you don't improve, it may be time to consider fixing it. And really the two things I hear from patients that tell us when it's time is, doc, I have pain that wakes me up at night. And doc, I have pain over the lateral or outside part of my arm. Those two things are very consistent with rotator cuff tears.
That pain pattern coming down the side, that's generally what I look for as well. So you're saying when they have that more constant, or does the pain shift sites?
Yeah, I think this, it's a rotator cuff tear until proven otherwise. If the pain is on this outside part of the arm, it's not biceps tendon, it's not labrum, it's likely not, arthritic change in the shoulder. Those two things are cuff tear until proven otherwise if they have night pain and they have pain over the lateral aspect of the arm.
Mm-hmm. You just touched on an interesting point talking about that cortisone shot, and I had a conversation with an old colleague of mine a few weeks ago, and we talked about the healing process.
Yeah.
And really, the rotator cuff has poor vascularity, doesn't get a lot of blood supply, and so the healing in that part of the body is difficult.
Absolutely.
You want the body to lay down healthy tissue, but you get instead sort of this mishmash of cytokines and things laying down this tissue that doesn't heal well. What are they doing, or what are you doing to try to, if you go in there and do surgery, what can you do to try to get better scar tissue, less scar tissue in there?
Yeah. That's a really good point. And it is this healthy balance of scar tissue, right? Is the human body doesn't heal by recapitulating its normal tissue, right? I always use the example of salamanders. If you cut off a salamander's tail, it regrows its tail, right? They have the ability to regenerate their tissue. Humans don't. So when we heal, whether it's the rotator cuff or anything else for that matter, it heals by scar tissue formation, right? You never get the same organized layers of tendon and insertion of tendon and bone when we do the surgery. When we do a successful rotator cuff repair, we actually get scar tissue healing in that interface. And there are a lot of really smart people doing research on how we can harness some of what some animals do to heal, to recapitulate our tissues, but we're just not there yet. So in the interim, we're doing things like adding biology that helps promote scar healing as best as possible. And that's things like when we do the arthroscopic surgery, we bring those healing or biologic factors from the bone. So we punch holes in the bone where the tendon inserts to help bring some of that healthy bleeding tissue out of the bone. Sometimes we use patches or augment the healing process by putting on grafts or things that can help augment the healing, and sometimes injections of things like bone marrow aspirate concentrate, which is arguably the closest thing we have right now to stem cells. That's FDA approved. There's no stem cell treatment right now that's FDA approved. So doing things like taking aspirate concentrate from the bone marrow or from adipose cells from the patient helps us bring the best biology possible to the healing site.
Would you typically take that from the patient's own body?
Yeah. So if we're worried about someone's healing potential, that's when we start augmenting with things like bone marrow aspirate or adipose-derived cells, or even PRP for that matter. Anything we can do to help promote healing in that area.
Mm-hmm. What about somebody with a shoulder labral tear? Because we see those all the time too. Do you have a similar sort of clinical thing? You said 6 weeks physical therapy if it's rotator cuff.
Yeah.
Is that the same with labral tears?
Yeah. So I put labrum tears into different buckets or categories. The anterior labrum, or the front part of the labrum, is really important, especially the inferior anterior or the bottom anterior portion of the labrum is really important for the stability of the shoulder. The posterior back part of the labrum is more of a pain generator, and the top part of the labrum, or the superior labrum, is really intimately associated with the biceps tendon. So those are like the three main sectors of the labrum. People who have anterior labrum tears tend to get shoulder instability, meaning they feel like the shoulder can sublux or dislocate, or they've had those events and that's why they have a labrum tear in the front of the shoulder. The posterior labrum is typically heavy weightlifters, people who bench a lot and drive the humerus or the humeral head posteriorly or back on their socket or glenoid, and they shear off the posterior labrum. So that's more of like a heavy lifter type shoulder pain. And then people who have biceps tendonitis or biceps pain and labral tears tend to be overhead throwing athletes or overhead laborers, people who get pain along the superior aspect of the labrum or top part of the labrum. So those are kind of like the three main buckets for me. And it's figuring out if those people are going to do well with, like you mentioned, non-surgical treatment, physical therapy, potentially injections, or if they've done those things or exhausted those modalities, is it time to have conversations about biologic injections like PRP or bone marrow aspirate, adipose-derived cells, or is it time to consider a surgery?
That's a good point. So let's just say 6 weeks of PT didn't help.
Yeah.
Then you go and you say, okay, let's reevaluate. What then is your decision-making process when it comes to either orthobiologics like injections or surgery? What are your criteria there?
It's a really good question. I think doctors have different personalities, and I'm very big on making these decisions with the patient, meaning I present information and data, and then we decide together where we're headed, right? And I think it's different in the athlete world than it is potentially in the non-athlete world, whether it's a high school athlete or a collegiate athlete or a professional athlete. There's timelines, right? And sometimes those timelines are based on seasons. Sometimes those timelines are based on contracts, right? And so those timelines help dictate whether we have time for more non-surgical intervention or whether it's time to pull the trigger on either having surgery or not. And then I think in my day-to-day practice on recreational athletes and the general public, I really like to just present the data and the options, what's available, and then make a decision with the patient based on their comfort level and preferences. And I think, as a surgeon, the more non-surgical care I do, the more patients I see, right? No one wants to go to the surgeon who's like, you come in with an MRI report and the MRI report has something that says you can operate on that person. And then without examining them or talking to them, you say, oh, you have a labrum tear, you need surgery, right? So
let's take, I just want to illustrate this because this is interesting to me. I'm sure it will be to other people. Let's say you have a professional hockey player. There's a timeline, there's a contract, there's a lot at stake there in terms of that, their career. And then you have I walk in and we have the same injury.
Yeah.
I need mine for my job, but I can get through. Like I could get by,
Yeah.
It seems to me like they're going to opt for surgery more quickly with the professional athlete, potentially. Correct me if I'm wrong. They're going to
Yeah.
be like, let's not waste time. Let's get right to it.
Yeah.
But a patient then comes to me and says, well, why wouldn't I just do that? I'm not a professional athlete, but if I'm just wasting my time potentially, how come they would do it but not me? Is that
Yeah.
based off of like, well, we don't want to wait 6 weeks and see, so we have the resources available. Let's just go for this. Is that how it kind of works? What's the conversation like when you're going over those things?
Yeah. Yeah. I think that's in part how the conversation goes. I think it depends on the injury, time of season, right? What are the long-term implications of managing that injury non-surgically and managing that injury surgically, right? So if we're let's say we're dealing with a shoulder dislocation with an anterior labrum tear, right? If it's the first dislocation, we're probably rehabbing them and letting them return to play, especially if it's during season, right? If it happens a second time, potentially the conversation shifts. But typically for in-season athletes with shoulder dislocations, we're managing them non-surgically till the end of the season. And then we're treating it in the off-season surgically so they can have a stable shoulder for the following season. If we're talking about Joey and his practice of work, but also in life, right? You're a super fit dude and you like to work out. If you have one shoulder dislocation, we're going to rehab you. If it comes out again, we're probably going to have a conversation about surgery, right? And part of the reason for that is we know the natural history of the shoulder coming out of place creates cartilage damage, it leads to arthritis over time, right? But if, let's say it's a superior labrum tear, the shoulder's not coming out of place, you just have pain when you do heavy lifting, you're not making yourself appreciably worse, treating that non-surgically for the rest of your life, right? So when would we have a conversation about doing surgery for it? Well, when you come to me and say, listen, doc, like, I hate this thing. I can't lift as heavy as I want. I can't do the activities I want to do on the weekend. Like, it's affecting my quality of life. Then we're having a surgical conversation.
Mm-hmm. Yeah, so much of it is about it's subjective, it's
Right.
contextual. So there's not just one size fits all. I think it's an important thing for everyone to know. Really, it's like, oh, it's not as cut and dry as yes, cut here, don't cut here, this here. It's
Exactly.
there's every situation is unique. And
Absolutely.
actually, that's part of the reason I love working with you. I mean, working with you is just, I sent some clients
Yeah.
there, and it's
Absolutely.
because
Yeah.
I've known some folks, and there are definitely folks that are more surgical happy, and they don't necessarily
Right.
have the conversations, because I hear it all from the patients.
Right.
And so that's what I appreciate about your practice and how you approach things. I just,
Thank
to
you.
me, that's the right way to do things. So
Yeah, absolutely. I think so
phenomenal.
too. And I appreciate that. I appreciate
Of
you saying
course.
that. And that's why we share clients, man.
And that's
Because,
right.
you know,
Like attracts, well, you can sometimes like attracts like, but also sometimes opposites attract. I never know which one it is. It seems to be interchangeable. Anyway,
well, I think what it is that you take good care of patients and you have a good personality. And so
personality is huge.
I think people who take good care of patients tend to stick together.
Let's talk a little bit about the elbow. Treating golfer's elbow or tennis elbow, I don't usually use those terms. I like medial epicondylitis. You know what?
Yeah,
Those are difficult. What
totally.
I have patients that get medial epicondyle pain from doing pull-ups or
Yeah,
whatever, and I've seen that last for over a year sometimes with consistent
100%.
treatment,
Yeah,
shockwave. What's your take on those types of injuries?
I would say the exact same thing you just said, honestly. Like, probably the first time I see those patients, I'm like, I tell them it doesn't matter how we treat this. It could last 6 months or it could last 18 months. And I think those are particularly hard things to treat. And you're right. It's a degenerative change of the tendons on either the inside or the outside part of the elbow. And it gets acutely flared up, but ultimately a lot of stretching, strengthening, oral anti-inflammatories, injections, occasionally surgery to remove the degenerative part of the tendon. But it's typically a non-operative treatment, and it's typically prolonged no matter what you do. Most people don't get it, and like 3 months later, they're like, wow, like I'm cured.
It'll just one day they wake up and it's gone. I hear that all the time. It's like, man, it was, and then all of a sudden it was gone. Is the same thing that applies for the shoulder with the cortisone injection applied to the elbow?
Yeah, good question. The short answer is no. I think there are roles for cortisone, and there are roles for other types of injections like PRP. And I think tennis elbow or golfer's elbow are two areas where both of those types of injections can be very helpful. So
that's what I've found as well.
Yeah.
Tell me if there's any validity to this.
Yeah.
There's a cycle of pain, inflammation, spasm, or whatever you want to call it. Sometimes with the cortisone, and what I've found when I've referred people for cortisone for the elbow is because we've run out of all other options. It will, a patient goes, well, isn't that just a Band-Aid? And I said, well, you know what? It might be, but I've honestly I've seen it where the patient's gotten it and it never came back.
Yeah.
It's like sometimes it's breaking the cycle potentially. Do you know anything, what that could be?
Yeah, 100%. You're 100% right. People ask me that question all the time too. It's like, isn't this just a Band-Aid, right? Whether it's with the elbow or shoulder or knee, sometimes it's just a matter of decreasing the inflammation enough to allow the physical therapy or the chiropractic care or the acupuncture or whatever the other modalities they like to use to be more effective, right? So the cortisone or the PRP it's not curing anything, but it's just decreasing the inflammation to allow those other modalities to become effective.
Inflammation is key.
Yeah.
I want to ask you this because I'm sure some listeners will be interested if you have a take on this. Tommy John surgery for younger athletes.
Yeah.
I mean, that's become a big thing in recent years. Baseball players. Do you have any opinion on whether that's a good or bad thing?
Yeah. So, I think that the rates of Tommy John surgery or ulnar collateral ligament reconstruction have gone way up, in part because young athletes are playing the same sport year-round and are throwing year-round, right? And we've seen pitch counts and things like that come into play to help protect these young athletes from having those injuries, overuse injuries. And I think there's also been some misinformation about why people are getting Tommy John surgery and what the normal or average recovery is actually like. Because I think parents, and there's actually been some studies polling parents looking at their perceptions of Tommy John surgery. And I think there's a vast majority of parents who think that if a kid injures their elbow, has Tommy John surgery, that they're going to come back throwing harder and better than if they than they were prior to that injury and surgery. And while some do, that's not the norm, nor is that the intended purpose of the surgery.
Is that is that a result of watching Rookie of the Year too many times?
Yeah, exactly.
Wasn't that movie? Kid breaks his arm and he comes back and he's just like a phenom. I just remembered that movie.
Or was
it Angels in the Outfield? Maybe it was. I can't remember.
No. You're right.
Rookie of the Year.
Rookie of the Year. The kid breaks the arm, comes out of the cast, and has like a live arm all of a sudden. Yeah. Until he makes it until they make it to the World Series, and then something happens. And
that's right.
He's got to throw underhand to the slugger.
That's right.
But this is a phenomena actually more recently than that movie. It's within the last decade, I think, and it's in part because the surgery has gotten very good, meaning the techniques for the surgery are good. You can really do a nice job now restoring the stability of the inside part of the elbow. But that the results of the surgery are not making people throw harder or better. It's that these people recover and heal and then continue to progress and go back to playing. But I think that overuse injuries are a major thing, not just in the elbow, but I think baseball throwing athletes are a good example of where we see overuse throwing injuries.
I noticed I grew up in Montana, and I played soccer, and we played 5-6 months out of the year, and then we'd go indoors. But during the winter, there was much less activity,
Yeah,
and our team would go to regionals or whatever. We'd play these Southern California teams and just get, not always, but usually, our asses kicked. These
yeah,
other kids were playing year round, and obviously there's a larger
yeah,
population. You have a lot of factors. But when I moved to California, Southern California, 13 years ago, and I started treating
yeah,
patients, that's one of the major things I see is there's year round. I mean, you could play baseball, AAU or whatever they have,
yeah,
high school, all year
yeah,
round they're playing. There's so many overuse injuries in younger athletes. And
absolutely.
it's
Yeah,
difficult because I try to, depends on the situation, but it's so obvious, and you say, man, the kid needs some time off. But the kid
yeah,
loves it.
absolutely.
It's
Yeah,
not necessarily anybody's fault. It's just natural. It's like, oh, well, we're going to put him in soccer camp, and then they're going to play on the,
yeah,
how do you have that conversation with and just say, hey, listen,
all the
this isn't over.
time, all the time. Like what you just described is 100% correct. And I think you're right. Initially, I was going to respond saying it is someone's fault, but it's not someone's fault. Like the kid loves it, mom and dad love it. It's the social network, whatever. But I will say that there's a lot of pressure put on the kids to, like if you don't play on the summer ball team, you're not going to be in the fall ball. You're not going to be with the kids in the fall ball. So, uh, I think the social norms and the pressure has been put on that you have to stay with the same kids year round, or you won't be able to link back up in the like main season, which it makes it hard for these kids and the parents to say, hey, look, like Tommy loves baseball, but in the fall he's going to play basketball, right? It makes it hard. I hear it all the time from the parents. It's like there's like peer pressure from the coaches and the club organizers to keep the kid, in the cycles with all the other kids, when really they should all be taking a season off to play another sport, and I think there's also there's been some studies or people have looked at this, like the vast majority of professional athletes are not the ones that start at age 4 and play basketball. The NBA is not full of guys who started at age 4 and just played basketball until they were 20, right? That's just not the
Fascinating.
way it works. Or hockey. Hockey may be a little bit different, but basketball, baseball, football, like the body also is not made to take so many revolutions, so to speak. And so sometimes the best athletes are those that develop in other sports and don't sustain some of these overuse injuries or get burned out, who are just great athletes and who fall in love with the sport later on in life. So,
That's fascinating.
I think that it's just hard. You fall into these cycles of like peer pressure from the other kids, from the other parents, from the club organizers. Like you just get stuck in these cycles and it's tough.
I remember growing up in a small town, and we'd hear these like rumors from other
Yeah.
athletes in big cities like SoCal, and be like, oh, they had to sign a waiver that they wouldn't go skiing this winter because the coach didn't want them to
Yeah.
get hurt. And we
Yeah.
were all in awe of stuff like that. Like to us, it was just like, we're going skiing, it's winter, like,
Yeah. Yeah.
So we thought, it was like, man, that is next level.
Yeah. I mean, also like it's probably amplified like where we live, right? LA is a crazy place about everything, right? And this is probably just another example. Like if you're in like, I don't know, middle America somewhere, maybe some sports are more fanatical than LA and maybe some are less, right? But I think LA is also a pretty wild place.
Yeah, that's for sure. What about leading up to surgery? Let's say you've made the decision. How
Yeah.
important is prehab or
Yeah.
nutrition? Are you giving patients that type of right, those type of recommendations leading up to surgery?
Yeah, that's a great question. I think that so prehab is certainly important for certain injuries. So like for example, ACL tears in the knee, right? One of the more common things that I take care of and that we see, especially in young athletes, the high school athlete, probably one of the most common things I see is ACL tears. And we know from good data, from good studies that prior to having an ACL reconstruction or having surgery on your ACL, it's important to get the swelling out of the knee, get your quad firing again, and get your motion back, meaning you should be able to fully straighten your leg and you should be able to bend your leg probably 105 or 110 degrees. And you probably should not have surgery until you can meet those goals. So for some athletes, like at the collegiate and professional level, when they tear their ACL, we take the fluid out of their knee, right? They come to the office, we drain the fluid out of the knee. So that gets rid of the swelling. And then they do rehab like 6 hours a day and they're ready in a week to have surgery. But for like the common recreational athlete or the high school athlete, it may take 3 or 4 weeks to get to those goals. And that's when you have surgery. So prehab for ACL is super important. Prehab for some of the other stuff, maybe not as important, right? Depending on the injury pattern. But ACL is a big one for prehab. And then I think the second part of your question is an area that I think is under discussed and undervalued, but really should be a bigger part of what we do as orthopedic surgeons. And I've always thought, maybe this is something you and I chat about for future endeavors, right? But like, there's not like a holistic approach to human performance. By performance, I mean maybe even just being able to go to the gym and do your job, right? That's still performance for that athlete or individual. There's not a holistic approach to it, right? You go see the surgeon for the surgery, you go see the physical therapist for physical therapy, you see the acupuncturist, chiropractor, you see all these people, but they're not really linked. You get word of mouth referrals, maybe so-and-so says, go here, go there, but it would be great to have a holistic approach. And I think that holistic approach includes nutrition, sleep hygiene, all of the things that we know really matter for performance and for well-being. And they're certainly not discussed in most orthopedic surgeons' offices, right? Like, are you sleeping well after your surgery? Are you getting enough rest? Are you eating enough protein? All of those things matter in healing, and there's just not an emphasis on it. I'd love to hear your thoughts on that too. I know you are interested in this world as well.
Well, healing to me is very interesting because healing seems to be very individual. And I know there's a lot of factors. I mean, genetics is huge. We all heal differently. And Lenny and I talked about this a few weeks ago. An injury is easy. There's a structure becomes separated, or there's I can't think of the word, a separation of tissue essentially. But how that heals is going to vary. And I mean, I've had patients have surgery, shoulder replacements, whatever it is, and they heal and it's like nothing happened. It's crazy.
Yeah.
And then other patients that you would assume would have similar, same type of body type, roughly the same activity level, and they just have problem after problem after problem. And there's a lot of variables that go into that. But let's just say, the surgeon or whatever, the nerve wasn't nicked, everything went well. There is no doubt that there's a difference in how we heal. And so, I've read some stuff on, different supplementation and things like that. So anti-inflammatory type things, but it gets complicated because, I mean, an anti-inflammatory diet that one person has is going to set somebody else off. I mean, if the biggest thing that I keep learning and I'm always reminded of in these fields of medicine is like, there's not a one size fits all thing for anybody really. I mean, there's there's correlations, of course. So
Yeah.
yeah, it's fascinating that whole thing. Listen, that's what I do. I try to teach good sleep.
Yeah.
How you sleep, how much you're sleeping, calming the nervous system down with nature walks and all that kind of
Yeah.
more holistic stuff. So,
Yeah.
we do our best to try to impart those ideas onto patients.
Yeah.
Because it all
I
makes a
think that,
difference.
yeah, it does. I think it's a fascinating topic, and I think everyone, not everyone, but lots of people are looking for a quick fix, right? Like, doc, just do the surgery, like it's going to get better, right? And there's so, like you said, there are so many variables that go into having a successful outcome and recovery, and no one wants to hear like me preaching about their diet or how much sleep they're getting. They just want like the surgery, and they want to heal and go back to their life. But those things matter. And there's, also because we're in LA, right? So many people are taking oxandrolone, an oral anabolic steroid. So many people are taking growth hormone, and peptides have become like a huge thing, right?
Mm-hmm.
And they're understudied and overprescribed, right?
Peptides are running rampant.
Yeah.
Yeah.
And like, we just don't have a lot of data, but I think LA is a very unique place, right? Everyone wants to look better, look younger, preserve their age and activity level. And so from a scientist standpoint, from my standpoint, it's like a great place to study those things, right? Because we have people who are highly motivated to stay young and fit and active. But I think this whole world of more of a holistic approach to healing is very, very interesting.
Mm-hmm. You kind of got into some ACL and knee stuff, and I want to get to knees because
Yeah,
I know a lot of people will be
yeah,
interested in that, but I'm just we'll work down the body,
yeah,
and I wanted to
yeah,
go to the hip first.
yeah, sure.
I got so many questions about the hip. I have so many questions in general,
Yeah,
but when it comes to the hip,
yeah,
okay, and I think even the lay person, I think it's kind of common knowledge that a labral tear in the hip, because there
hmm,
was a study or studies that were done, I don't even know when, but it said
yeah,
if you if you operate on a hip labral tear, they show that it's going to be worse. You're going to get more arthritis.
yeah,
What's the recent research on that? What's your take on that?
yeah,
You've studied this and
yeah,
researched it.
yeah. So I think that the early days, which were the late 90s and the early 2000s of hip arthroscopy, were not great, meaning um, there's an experimental phase a little bit, and people were debriding the labrum rather than repairing it,
Can you explain
right?
what the debridement is?
Yeah, yeah. So people would get labral tears, they'd get MRIs. If you show a labral tear, they'd have symptoms of kind of deep stabbing grind pain. They'd go to see an orthopedic surgeon. The orthopedic surgeon would say, the source of your deep stabbing grind pain is your labrum tear. We need to go trim it out. And so patients go to the operating room. The surgeon would put a camera, arthroscopic surgery, into their hip, and they would just shave out the labrum. And temporarily, those symptoms would improve, right? The pinching, stabbing pain would go away because the structure that was getting pinched is no longer there.
I'm going to
But
interrupt you real quick. I want to hear
yeah,
your thought, but just so people,
yeah,
because I get this, the labrum
yeah,
anatomically, you have this hip socket,
yeah,
and then you've
ball
got
and
this
socket joint. Yeah,
cartilaginous cap that extends beyond those edges, and that's the labrum.
yeah, yeah. So the
Okay.
labrum sits like largely circumferentially on the edge of the socket, and it helps kind of deepen the socket, stabilize the joint. It creates what we call a suction seal for the ball and socket joint of the hip. And that structure is very important for stability of the joint, and removing it creates some instability of the joint, and instability leads to some extra motion, which over time leads to wearing out the cartilage. So the labrum is a very important structure to preserve. And so when people would have labrum tears and it would get trimmed, initially their mechanical symptoms of catching or stabbing pain would go away, but very quickly over time, because they lost that suction seal to the hip, they would develop arthritic change and their pain would return. And now very quickly they would need either injections to diminish the pain or a hip replacement to ultimately solve their problem. So those were the dark days of hip arthroscopy. Now we know that we need to preserve the labrum, meaning stitch it up when it's torn rather than trim it out. Having said that, the reason the results of hip arthroscopy are so varied is because I think there are a lot of surgeons that dabble in hip arthroscopy who don't necessarily do the best job for the patients. And while they may repair the labrum, they may also be bumping instruments into the cartilage surfaces of the joint. And those bumps into the cartilage result in a very quick process of osteoarthritis, meaning the cartilage lining on the end of all our joints is very sensitive to mechanical stimulation. And if you bump into it or damage it, it leads to arthritis pretty quickly.
Wow.
So it's very important to pick obviously it's a surgeon talking, but you want to find surgeons who do the surgery you need very frequently, right?
Mm-hmm. Reps.
It's just like anything else in life, right? You want someone with a lot of reps. You want someone who's done that surgery over and over again, who can do it in their sleep, who can give you a name or two of patients that have had that exact same surgery that have done well. I oftentimes, I will tell patients all the time, like, let me give you a name or two of people who have had that surgery, who have done well. You can chat with them, right?
Mm-hmm.
Because I think it's important to find someone who does it routinely and all the time. And we have lots of data in our world, in the orthopedic surgery world, that show that complications in surgery are related to reps, meaning the more reps you have, the lower the complication rate is.
Mm-hmm.
And the surgeons who do it once or twice a month are the surgeons that run into more complications.
Yeah.
So I think that's where hip arthroscopy early on kind of got a bad rep. And I think that it is important to pick a surgeon who can say, yeah, you have a labrum tear. Let me find 2 or 3 patients that have, are in the same demographic as you. If you love yoga and that's your thing, and you have a labrum tear and you're considering having it fixed, let me put you in touch with 2 or 3 other yoga practitioners that I've done this surgery on who have done well, right?
Mm-hmm.
Who have the same demands of their hip, and I can say, yeah, go talk to so-and-so. They can kind of give you the lowdown on how this is going to go.
So what does a workup on the hip look like? Is this the same kind of thing where you have a pathognomonic or some type of pain pattern that says this is a hip, the labral tear until proven otherwise? And then is it physical therapy?
Yeah. So for the hip, the vast majority of like the young athletes we see with hip pain come to us because of labrum tears. And the vast majority of the labrum tears are related to underlying bony conditions. So, Joey, I know you know this, but I'll say it for the listening audience is that, labrum tears come from bony changes around the hip, and those bony changes are typically either what's called femoroacetabular impingement, or FAI. That means you either have a little extra bone growth on the socket, or you have a prominence of bone on the femur, thigh bone, that bumps into the labrum when you get into like deep squatting positions, or you have a condition where you don't, right, exactly, or you don't have enough bone coverage on your socket, and that's called hip dysplasia. And when that's the case, the labrum has to pick up the slack for not having the bone of the socket. And so the labrum actually tries to serve a role of stability, and in that process gets torn. So when young athletes or active people come to me with hip pain, it's typically either deep groin pain so along the crease of the groin or in the front pocket. And they describe kind of mechanical or sharp stabbing pain in certain positions, or they have kind of deep buttock pain, or they have lateral base pain or on the outside part of the hip. And so typically the deep groin pain is from labrum tears. The buttock pain typically is either from labrum tears that present with what we call atypical hip pain, or it comes from muscle imbalances or fatigue in the glutes because of pain in the hip joint. And then typically the laterally based pain is from either the IT band or trochanteric bursitis. So we first figure out where their pain is based on location. And then through the exam and what the patients tell us and x-rays, we determine if an MRI is the best next step. And typically we get MRIs to look for labrum tears. And when folks have labrum tears, like you mentioned, I think everyone's entitled to at least 6 weeks of physical therapy with a good therapist to see if they can increase their glute and core strength. A lot of times they can take the stress off the hip joint and their pain goes away. And it brings up a good point, which is that not every labrum tear needs surgery. And so many times, I have patients come to the office and say, "Doc, look, so-and-so ordered me an MRI, has a labrum tear. I heard you're good at fixing these, like, let's fix it." And I have to kind of pump the brakes and say, listen, like, there's probably, I always say, like, at age 50, probably 50% of the population has a labrum tear that's asymptomatic. So when people come and they're 50 years old and they have a labrum tear, I say, let's just make you one of those 50% of the population that has an asymptomatic labrum tear. And typically we can do that with physical therapy, sometimes a PRP injection or, a cortisone injection, calm the inflammation down and strengthen the muscles, and your pain's going to go away.
Those bony changes you mentioned a few minutes ago, where you said that the bone is hitting the labrum. Those are most common. Those are frequently because of overuse, where the body's laying down new bone. Is that correct? Like a stress response where the body's creating that FAI, as opposed to a genetic variance, correct?
So we think that for those people who have bony overgrowth on either the femur or the acetabulum, we think that it's in part related to their genetics, like what mom and dad gave them. And we think it's in part related to the growth plates around the hip. So where that, especially on the femur, where that extra bump of bone typically grows is right next to the growth plate. And we think it's very much related to the activities that person does while their growth plate is still open. So that's why we see it in so many young athletes, is because we think that the stresses that they put on the hip joint while the hip growth plates are still open probably result in those extra bumps of bone.
Yeah, I remember a study was on young soccer players that played, and it was very strong correlation between these FAI bony growths and the amount of soccer they were playing. And these were like 15-year-olds. It was like they were young.
Absolutely. Yeah, absolutely.
So
we see it in soccer, hockey, water polo is a big one in Southern California. Like the egg beatering motion of water polo is not so great on your hips, quite honestly.
Yeah. Injections in the hip. You mentioned cortisone a minute ago.
Yeah.
Let's go to cortisone again, because I'm fascinated with that. Because we've got, now for shoulder, we've seen that it's maybe not great, or
cuff
even
tears.
detrimental. Cuff tears. Elbow can be beneficial. What about hip?
I think for the young active athlete with no cartilage damage in their hip, I'm very hesitant to give them cortisone. I think if we need to kind of settle the hip down, if it's an in-season athlete, we're talking about PRP.
Platelet-rich plasma.
Yeah, platelet-rich plasma as a strong anti-inflammatory. And so I'll just go on the record and say that, there are people in LA who say, like, oh, get a PRP injection, it's going to fix your problem. It's going to repair your labrum or fix your rotator cuff or regenerate your joint cartilage. That's absolutely untrue. There has never been a study that says that's what PRP is good for. We think that PRP is a very good anti-inflammatory. It provides, growth factors and healing factors from the blood that helps decrease inflammation, but it's not going to rejuvenate your joint. So I think, again, it breaks that cycle of inflammation and allows the physical therapy, chiropractic care, acupuncture to be helpful, or more helpful than it was when you didn't have the injection. So cortisone in the hip, I think, is great for people who have some arthritic change already, for people who maybe are waiting for a hip replacement but aren't quite ready, for people who don't plan on having surgery either ever or in the near future. But I'm not super inclined on giving cortisone to young athletes with like hip impingement, FAI, and labral tears. I think, yeah, go ahead.
I just was curious about what about the bone marrow aspirate?
Mm-hmm. So I think PRP and bone marrow aspirate are both good options, again, to decrease inflammation. It's not going to repair your labrum. But again, there are a lot of people running around with asymptomatic labral tears.
Mm-hmm.
I think that's what we strive for a lot of patients.
Yeah, I've got one in my left hip. I played soccer for many years and a lot of other sports. Yep. And every once in a while, man, it'll just grab me and I'll be stuck. It's like a sharp knife. It usually happens for whatever reason in a grocery store. I'll like go down to I'm like down in the bottom row and I'm going all the way down and I'm crouching and then I'll be stuck. I remember like a few weeks ago, I went down and I was like stuck on the floor. I was like, I can't move. And it's just like, I just got to wait 10 seconds. And then, but with the workouts or whatnot, I keep it totally at bay. And I always, I often will tell patients, hey, listen, the MRI might show you got a labral tear, but similar thing. Let's give this a while. Let's do some strengthening because a large percentage of these are going to be fine on their own. But
Joey, I wish there was some way to like spread that message widely, right? Like you're so sensible about yours. Like I just wish like more of the population could be like that, right? Is people just come and they say, listen, doc, I have a labrum tear on my MRI, like it's got to get fixed. And the truth of the matter is it doesn't. And I probably lose a lot of patients that way who want to go to a surgeon who's a little more aggressive. And then they have a bad surgery and then their hip freaking kills them, I don't know. What's your strategy? What do you think we need to do to like you're living with a hip labrum tear and it's like you live a very full life. So how do I convey that to people?
That's, in my case, I've always thought lead by example. Yeah. Now, that's not going to be, I think really it's just about education, man. It's about having a conversation with somebody and it's at the end of the day, it's like, listen, this is how I do things. This is the best way that I see fit. This is what I would tell my child or whatever. And, some people aren't going to like that style, but a lot of people are. And I think it just really comes down to having open, honest conversations and not just trying to get someone's business. Yeah. You just do the best you can and educate people. Yeah. That's a big part of what I got. I love educating and, listen, and we're always constantly learning too. So we just have to, we give the best advice we possibly can with the patient's best interest in mind. Yeah,
totally agree.
So, you don't do hip replacements, do you?
I don't.
Okay.
Shoulder, but no hip or knee replacements.
Okay, that's right. Shoulder replacements you do. Okay.
Yeah.
I've had 2 patients now have shoulder replacements.
Yeah.
They were great. They recovered really well.
I think people who have shoulder replacement done for the right indications are probably my happiest patient.
Mm-hmm. Hips nowadays are great too. I mean, those have been for a number of years now. A lot of, my sister had one recently, and there's a lot of fear around it. It's a big surgery, but nowadays those are pretty darn good.
Hip replacement is the best surgery in orthopedics from a patient satisfaction standpoint. So I remember there was some survey when I was a resident that came out about patient satisfaction from surgeries. Number 1 was cataract. surgery. That's when you basically go from not being able to see to being able to see. That's, patients are pretty happy about that. Number 2 is breast augmentation, and number 3 was hip replacement.
Huh.
So people are if you have an arthritic hip and you have a well done hip replacement, people are very, very happy. They return to all their activities. I think now mostly hip replacement is done as an outpatient surgery. You don't even need to stay in the hospital. You get up and get moving with a walker or crutches right away. And by 6 weeks, life is pretty good. Your groin pain is gone, and by 3 months, like most people are like, it's in the rearview mirror.
That's fascinating.
So,
3 months, and
yeah,
if you saw what they did to your hip, it
yeah,
is gnarly. That's amazing. I meant to ask you this. I want to backtrack just a
yeah,
little bit and talk about
yeah,
recovery times. So if we go back to rotator cuff,
yeah,
arthroscopic rotator cuff repair, what's
yeah,
your average recovery time on something like that?
yeah. I think 6 months is a good frame of reference. I think people are getting, I basically break it down into 2 weeks in a sling to allow the biology to get a little bit of a head start in healing. From 2 weeks to 3 months, you're working on range of motion with not a lot of strengthening. And then from 3 months to 6 months, you're working on strengthening with kind of a full return to unrestricted activities at 6 months. Some people go a little faster, some people go a little slower, but I think 6 months is a pretty good timeline.
Similar kind of timeline with labrum for the shoulder?
Yeah, absolutely.
Yeah.
Yep, I think so.
Why does a shoulder take 6 months and a hip 3? A hip replacement?
Yeah. It's funny. It's a good question because the hip replacement, it's probably our easiest joint to kind of recapitulate with metal and plastic. And it really is a ball and socket. There's no translation. You just need to recapitulate the ball and the socket. And if you do that well, and you don't disrupt the soft tissues too much, it's actually pretty straightforward. So it's a great joint to replace. It doesn't have the same kind of kinematic profile as like a knee, for example. The knee is very hard to replace, and people have hip replacements and feel normal. They say like, "Doc, my hip feels normal." You very rarely find people who have a knee replacement who say, "My knee feels normal." And honestly, you almost never hear that, right? And it's because of the complexities of the knee joint compared to the hip joint.
Yeah. The socket of the hip is deep. It's stable. Whereas you take the shoulder and it's like a golf ball sitting on a tee. So the hip is like this. A lot of stability. And then you take a shoulder, a glenohumeral joint. And so there's a lot more to stabilize there. And then as you said with the knee also, it's a different joint.
Yeah, there's flexion, extension, rotation, translation. So like the knee is just a lot more complicated to get right, and for people to feel like they have both stability and mobility is much more difficult in the knee than the hip.
Let's go to the knee.
Yeah.
You do a lot of ACL reconstructions.
Mm-hmm.
What does that mean?
Yeah. So the ACL, or anterior cruciate ligament, is a ligament centrally located in the knee. It connects the femur or thigh bone with the tibia shin bone. And it's really important for both controlling how the tibia or shin bone translates or moves forward in relation to the femur or thigh bone. It's also very important in controlling rotation of the tibia in relation to the femur. So how the shin bone rotates in relation to the femur or thigh bone. And it is a very commonly injured ligament for athletes. There are a number of both patient-related risk factors as well as environment-related risk factors for ACL tears. And most people who tear their ACLs do it playing dynamic sports, cutting, twisting, rotational, jumping sports. And most of the people who tear it want to go back and do those sports or activities. And in order to do so, you need an ACL. So you either need what's called an ACL repair or an ACL reconstruction in order to go back and do those sports. So repair of the ACL is somewhat a controversial topic, but there may be some tear patterns of ACL that lend themselves to more of a repair. The vast majority of ACL tears lend themselves to a reconstruction. And a reconstruction means that we remove the torn ligament and we put in a new ligament that typically comes from either the patient's own tissue, meaning an autograft. That's either comes from their quadriceps tendon, their patellar tendon, or their hamstring tendons are the three most commonly used. Or depending on the patient's age and activity level, sometimes we use cadaver tissue, which means it comes from a donor. And arthroscopically, we drill holes in the bone of the femur or tibia, or femur thigh bone and tibia shin bone, and we put in that new graft and we fix it with either screws or buttons to hold it in place, and that over time becomes the new ligament ACL.
And taking that graft out doesn't have a negative effect on, say, the quad or hamstring?
Yeah, so when we use the quad tendon, we use a kind of a central slip of the tendon, and then the vast majority of the tendon is left behind and sewn together, and it doesn't recapitulate, but it scars and heals in such a way that the tendon is totally fine, as is the quad muscle. With the patellar tendon, same thing. We take a central slip of it and the sides are reapproximated. No residual weakness or damage to the tendon. With the hamstring tendons, people tend to strip one or two of the hamstring tendons for that graft. And my personal belief, and there is data to also support this, is that people lose some, or there's some studies that show people lose some strength in their hamstrings, which has never made much sense to me in terms of why you would use that graft, because your hamstrings are very important for the dynamic stability of your knee. So I've never been a big hamstring proponent.
You're a quad tendon guy?
Quad tendon, patellar tendon. Kind of the gold standard for if you polled 100 team physicians of professional and collegiate athletics, the vast majority would say their gold standard graft is the patellar tendon. Some would probably say quad. Very, very few, if any, would say hamstring. But there's some very strong regional differences across the country as to what people think is the best graft. But for high-level athletes, most people use the patellar tendon, some use the quad.
How big of a chunk are we talking here of tendon are you shaving out?
Yeah, so we typically, most ACL reconstructions in this country are performed with either a 9 or a 10 millimeter diameter graft.
Okay.
So it's typically about 1/3 or less of the total volume of tendon.
Gotcha. Yeah. And let's go to you. You talked earlier about the goals of prehab.
Yeah.
With ACL. Range of motion, get the swelling out of the knee, because any even a tiny amount of swelling in the knee just shuts down the quad. So you want to get patients to this prehab level, and then after you're going to do the surgery, and then what does the recovery look like?
Yeah, so recovery from ACL reconstruction, typically patients put weight on their leg right away. They use a brace and crutches to help them get around for somewhere between 2 and 4 weeks. Typically by 6 weeks, everyday life is pretty good in terms of just like walking and moving through the world. And then basically from 6 weeks to 6 months is a process of getting your full range of motion and strength back. And then for me, between 6 months to 9 months is really working into all your sport specific activity, typically with a clearance back to sports around 9 months.
I've had some patients keep living their life without getting a reconstruction.
Yeah, it's reasonable.
That's reasonable.
Yeah, I think it depends on their activity level, but it can be reasonable. Yeah.
Mm.
There's just actually, I would say, a somewhat deceptive but very widely distributed article about non-operative treatment of ACL, tears, and it was, I think, in the British Journal of Sports Medicine, and it picked up in the mainstream press. I think like New York Times, Washington Post, CBS News, NBC News, all published articles about this study. But all of that to say, I do think there are some people and some tear types that probably lend themselves more so to non-surgical treatment. So certain tears off the femur, where the vast majority of the ligament remains intact, it's just kind of ripped off the thigh bone. Some of those probably scar or heal to a certain degree and afford that person fairly good knee stability. And for those people, they can probably do quite well without surgical intervention if their activity level is pretty low, meaning they're walkers, hikers. They don't do a lot of agility or side-to-side mobility or cutting, twisting activities. I think those people do pretty well non-surgically. So, tell me about your people who did well without.
I remember one in particular who was actually have one. I just saw her. She's going to go run a marathon, but she skis and she has not had it repaired.
Yeah,
and she's doing all right. She's active. I mean, she's a smaller person in good shape. She's got good strength.
Yeah.
I never saw the MRI. This was anecdotal, sort of. I see her only a few times a year, maybe. But she seemed to be doing really well. You said earlier, I mean, because really when you lose the ACL or you lose that structural integrity of that ligament, you lose stability of the knee. And so if you're going to go and do your cutting and agility, like you are much more prone to injuring your knee further.
Yeah.
So, that one, when I have a patient says, "Oh, I still my ACL's torn but I'm living okay with it." I just say, "Oh, yeah, good for you. That's great. Make sure you stay strong and balance the forces around the knee joint by stretching and strengthening and, keep living your life. If you're happy living your life the way you are, great."
I have some comments about that stuff for sure.
Awesome.
So I think not every ACL tear is created equally, right? It doesn't always, the ligament doesn't always rip in the same place. Sometimes it rips off the femur. Sometimes it rips in the mid-substance. Sometimes it rips by the tibia or shin bone. And the velocity of the injury is not always the same, right? So sometimes we get an MRI and the ligament, the fibers of the ligament look relatively normal or healthy. It's just ripped away from the bone, right? Other times, someone injures their ACL and the thing explodes, like nuclear, right? Like there's no sign of ligament anywhere in their knee anymore.
Wow.
Right? And those two injuries are not the same, right? The 40-year-old who injures it skiing, right, is not the same as the high-level athlete who goes to make a cut on the soccer field and their knee or their foot stays planted and the knee buckles in, right? Those are not the same injury. They may have injured the same structure, but the injury is not the same. I think there are some people who have a tremendous amount of laxity from their ACL injury, and there are some people who have a little bit of laxity from their ACL injury. And some of those people who have just a little bit of laxity from their ACL injury probably can do a lot of activity, like the woman you mentioned who skis and she's light and fit and her dynamic stabilizers of the knee are very strong, meaning glutes, hamstrings, quads. And she may have a little bit of laxity in her knee, but it's not very appreciable in most activities. And then there are people who have one of these nuclear ACL tears, and they have a wildly unstable knee, right? Like when someone comes to me with an ACL tear and I examine them in the office, some of these people, their knee is, what my PA and I call like stupid loose. Just like you go to examine them and it's like you're moving their femur and their tibia like at your will, right? And then other people just have a very subtle 1 or 2 millimeter difference side to side between their two knees in the stability, right? And so it's not a one size fits all. Like, some surgeons will talk to you and they'll be like, oh, anytime someone tears their ACL on an MRI, they need an ACL reconstruction. And that's just factually not true, right?
Yeah.
And you know that from your clinical practice, and I know that from my clinical practice. Do I think the vast majority of people do well with an ACL reconstruction? Absolutely. But not everyone universally needs one, and not every tear is the same. And some people do very well without an ACL reconstruction, and other people try to do well without an ACL reconstruction, and they end up having repeat instability events of their knee, and that's dangerous. And that's what I wanted to bring up, which is when the ACL is torn and your knee is pretty loose, and you go back and you do cutting, twisting activities, and the knee buckles again and again and again, the structures which try to kind of like pick up the slack for your torn ACL is what's called the posterior horn of the medial meniscus, or the inside meniscus in the back. It acts kind of like a door wedge in the knee, and it tries to keep the tibia centered or close to the femur. And so the damaging part of having a torn ACL and trying to go back to those high level dynamic activities is that you're going to beat the shit out of your knee for the rest of your life.
Mm-hmm.
So if you do that, you have a propensity towards early arthritis in your knee and meniscus damage and cartilage damage. And we know that that's not super safe. So if you tear your ACL, if you're listening and you've torn your ACL, at least go get an exam. Doesn't mean you need to have surgery, but get an exam and have someone tell you, oh yeah, your knee is like a little bit loose, or your knee is wildly loose, and either completely avoid any cutting, twisting activities or have an ACL reconstruction.
Mm-hmm. So glad you brought that up. I mean, so if one structure is not doing its job, other structures are going to take up that slack.
Right.
And that's a really important theme for anywhere in the body.
Mm-hmm.
Compensations, but compensations can lead to overworking other areas. Yeah,
exactly.
All right, we've covered. Now I got to ask, cortisone in the knee.
Same thing. I think from when I started my practice 8 years ago to now, the amount of cortisone I give has probably shrunk exponentially. I think that, again, if people have wear and tear, cartilage damage, they're avoiding a knee replacement and they get great relief from cortisone injections, I'll give them one every 4 months or so until they're ready to have a knee replacement. But I think if we're dealing with a young person with a meniscus tear or a ligament injury, and they say, doc, I want a cortisone injection to like help with my pain, the answer is go see someone else. Young people with meniscus tears should have surgery to repair the meniscus. People who have more degenerative meniscus tears, meaning it's just wear and tear from years of activity, those either can be left alone, managed non-surgically, until they have flaps or free edges that are acting more like mechanical irritants, meaning if they have pieces which are displaced of the meniscus and it's like a hangnail, like it's rubbing and they get catching or clicking or popping, then we go in and trim those torn edges. But in general, this is a similar story to the hip labrum. A few generations ago, when people tore their meniscus, the answer from surgeons was just remove it. And then people realized the meniscus is a really important structure to help preserve the cartilage in the knee and act as a shock absorber. And then people realized, let's preserve the meniscus as much as possible. So if you're listening to this and you're 40, 50, 60 years old, and someone's told you have a meniscus tear and you're not getting mechanical symptoms of catching, clicking, or popping, leave that meniscus tear alone. Go see a chiropractor, physical therapist, work out in the gym to keep your muscles strong, but avoid having your meniscus trimmed, because even a torn shock absorber is better than no shock absorber.
Doc, is there any sewing that goes on with meniscus repairs?
Yes. So when we repair the meniscus, typically in a younger patient, we put in stitches to reapproximate the tear, basically pushing it back together and allowing it to heal. So like this week, I did a bunch of meniscus repairs in young athletes, and there are different techniques of how we do that. But the goal of doing a repair is to have the meniscus heal, meaning we want to promote an environment where that structure is going to heal or seal back together.
Mm-hmm. A lot of young patients getting meniscus repairs.
Absolutely.
Yeah,
absolutely. Anyone young, when I say young, I mean typically 40 or 45 and younger, who has a meniscus tear that's symptomatic, we're at least considering repairing it. And the blood supply to the meniscus is not stellar, especially, the capsule or where the far periphery of the meniscus is where the blood supply comes from. And then as you work towards the more central portion of the meniscus, the blood supply kind of peters out or tapers out. And so tears that are in the central or inner portion of the meniscus tend not to heal well, and those typically get trimmed. Tears that involve the mid portion of the meniscus or more peripherally into the capsular area or the lining of the joint, those ones we try to repair all the time.
Is the prehab for meniscus similar to the ACL, where you said range of motion, decreased swelling, similar kind of work up there?
It depends. Typically when someone tears their meniscus, they don't get a big effusion or swollen joint the way they do with an ACL. So typically, if we see someone with an acute meniscus tear, they most of the time maintain their motion and don't have a lot of swelling, and that therefore they can get right in the operating room. The caveat to that is there's some types of meniscus tears which displace. Specifically, there's one type that is referred to as a bucket handle tear of the meniscus. That's when the meniscus tears and kind of flips on itself in such a way that the knee gets locked, meaning you can't fully straighten it and you can't fully bend it. And when it's locked like that, that's not that it's a surgical emergency, but we don't try to have those patients get their motion back before they go to the operating room. We just know that they need to go to the operating room and have the meniscus reduced and repaired.
That just brought back a memory. I remember I was in the office one day and we have these windows that look out over Beverly Drive. Yeah. And one of the other therapists said, "Hey, there's a woman down here who's in trouble." She was down on the street level and she was sitting on the ground outside of a Range Rover, and she was clearly in distress. And so I remember I ran downstairs and I was like, I said, "What's going on?" She's like, my knee, I can't move my knee. I tried to get into my car and my knee is locked. And I carried her upstairs and it was clearly a meniscus.
That was very nice of you, by the way.
I didn't fully, I was like one arm over the shoulder. I didn't fully carry her, but she was a small woman. So I 90% carried her. And that's really common with meniscus, that there's that catching. And I just did a couple things and it just kind of clunked right back. And she was like, "Oh my God, it's completely fine." So, but that bucket handle, the catching not just with bucket handle, but that's really, catching, you said catching, clicking, popping with
Yeah.
meniscus. So for anybody listening with those symptoms, most
Yeah.
likely it's meniscal.
Yeah.
That was years ago. I just remember that.
Yeah.
Funny.
She needed your help.
um, let's see, where was I going to ask next? Recovery time with meniscus stuff. This is arthroscopic.
Yeah.
Seem to be pretty
Yeah.
straightforward recoveries, no?
Yeah, for sure. So if you get a meniscus trim, right, like just the torn piece needs to be trimmed out, I tell patients that no brace, crutches a day or two, but you can put your weight on the leg right away. By 2 weeks, everyday life is good. 6 to 8 weeks back to full activity.
Amazing.
If you have a meniscus repair, it's closer to 4.5 months back to full activity. And that's because the first 6 weeks, we really protect the meniscus to hopefully allow it to heal. And then between 6 weeks and 12 weeks is a progressive range of motion strengthening. And then from 12 weeks or 3 months to 4.5 months, you're building up strength and getting back to full activity.
Amazing. I think we've covered all the joints.
We have.
All the joints.
That was great.
Amazing. I mean, that was so much information. I got a few more questions, but in terms of the actual,
fire away.
I mean, that was incredible. I mean, that was like
Thank you.
Shoulder down to knee. We got it covered.
We did it.
You touched on this earlier, Alex, about the future of where arthroscopic surgery is going. It almost seemed like AI, like, the computers are going to tell you where to patch and where to do this. Can you, where is surgery heading? And also maybe if you throw in orthobiologics, like the stem cell thing, what's the promise of surgery in the future?
So to me, surgery wise, I think the place that we can improve is taking out some of the human error, right? Like even the best surgeons, we try to do, every surgeon tries to do each surgery the same way each time. It's almost like a joke, like surgeons will always say, like, don't hand me that instrument. Like, I do this the same way every time. Like, you should know what I need next. But you want it to be ideally the same way each time, right? Like when I do ACL reconstruction, I don't want the steps to ever deviate. I want to do the same things in the same order each time to make that surgery the most efficient, reproducible, safest, with the best outcome, right? But humans are human, right? And we're not machines. And so sometimes, we may do a step not entirely perfectly, and that may or may not necessarily have consequences on the outcome of that surgery. But if there was a way to reduce that, I think everyone would be in favor of that, patients and surgeons, right?
Yeah.
So where I see that coming into play in my world is, for example, let's use ACL reconstruction again. We have an MRI, which we can identify on that MRI where the ACL is supposed to insert on the femur, where it starts on the femur and where it inserts on the tibia. And we can identify on that MRI where those attachment points are. If we could superimpose those images onto what we see when we're in the knee arthroscopically or with the camera, right? And have a computer program say, drill here, not there, then we could very accurately put that tunnel in the same place each time, right? So there are ways in which we can introduce technology into the operating room in such a way where our hands are still doing the surgery, but they're being guided by the technology available to us.
That's
so
fascinating.
I think that's where my end of surgery is going. And I think that on the biologic side, I think I think that's the future of how we care for people, is providing better non-surgical treatments, right? Like, we spent a whole lot of time today talking about how cortisone is kind of a crappy medication, right? And we're looking for better alternatives to keep people out of the operating room, but with the potential to heal, right? And I think that's where, that's not the short-term future of orthopedics, but I think it's the more long-term future is, and I think that people assume like, oh, why can't you just harvest some cells which have healing potential and put them in and have things work? The problem is that those cells, like in a petri dish, need certain signals to go towards, the cells are immature, right? When people say this term stem cell, they're talking about pluripotent cells. What that means is a cell which can differentiate or be driven into different lineages of cells, right? So it's an immature cell, which, given, for example, in the musculoskeletal system, given the correct signals, can become tendon, can become ligament, can become muscle, can become bone, right? And in a dish, we can give it those signals and have it differentiate into a mature cartilage cell or bone cell. But when you inject it into the body, you can't tell the body to give those signals, right? The body is going to give the signals the body gives, the adult human body gives. And those may be anti-inflammatory signals, but they're not going to be, turn this injection into new tendon signals.
Mm-hmm.
So that's where I think the future of orthobiologics is there a way to use these pluripotent cells and turn on signaling in the human body so that instead of getting, for example, with the rotator cuff tear, instead of getting kind of scar tissue healing, which is how we currently heal, getting those very organized layers of tendon and then bone. And potentially we'll have injectables that help us do that.
The injectables that you can go get outside of the United States.
Yeah.
Are they doing that already? Or are they still in the realm of exploration?
They're still in the realm of exploration. So you can find closer equivalents of stem cells or pluripotent cells outside the United States than you can in the United States. But they are still largely novice, I would say, in the sense of they're great anti-inflammatories. They provide some healing component, but they're not super well targeted. And I think that's what the science says. If you look at studies in both the petri dish and in animals and in humans, we don't have great healing capacity with stem cell injections yet. And I think a large portion of patients who swear by these treatments, it's because they get great anti-inflammatory properties from the injections, and it decreases their pain. And I do think that there is a large placebo effect. And I've always thought this, and it would be interesting to study, but I think the more you pay for an injection, the stronger that placebo effect is. And I see that all the time with patients who have spent tens, if not hundreds of thousands of dollars on injections over the years and swear by them. And the science just isn't there.
Placebo is fascinating.
Yeah, me too.
Placebo is fascinating.
Me too.
Man, that's something I will continue to learn about, because it's like you said, I've seen that same thing. And anyhow, fascinating stuff. I hope we learn more about that in the coming years.
Me too.
Doc, how many days are you doing surgery per week?
So my schedule is I'm 3 days seeing patients in the office, and 2 days in the operating room. Tuesdays and Thursdays I'm in the OR. Monday, Wednesday, Friday I'm in the office. And then the USC athlete thing and the LA King thing is like a nights and weekends. You covering games in the evenings, travel with the football team on Fridays and Saturdays. You know, basketball is largely nights and weekends as well.
And he still manages to play golf and take care of his family. Gotta love it.
Yeah, you got to be well rounded.
I love it. And what on surgical days? What are you seeing? Depends on the cases, of course, but what's an average day? How many surgeries are you doing?
I do typically between 8 and 12 surgeries a day.
Gotcha. So some of these are relatively quick, an hour or less, or
Mm-hmm.
yeah.
So meniscus, ACLs, labrum repairs are pretty quick surgeries. Rotator cuff takes a little bit longer. Shoulder replacement a little bit longer. Hip arthroscopy a little bit longer. But I'm very fortunate to work with an excellent surgical team. Same people every time, my PA and the same anesthesiologist and CRNAs, and we use 2 operating rooms, which means I'm able to basically do twice the amount of work in the same amount of time. And my PA helps position the patients and puts them to sleep and gets them set up, and then I come in and do the surgery. And then by the time I'm done, then the other operating room is kind of cleaned up and ready for the next surgery. So I'm able to go kind of bounce back and forth and accomplish twice as much in half the time.
I got 2 more questions for you. The first one, I'm just curious. I just got asked this the other day.
Yeah.
Achilles tears in NFL.
Yeah.
Is that because of the surface? I mean, I know it's not cut and dry, but what have you heard about that?
I think surface is, with it's probably been studied the most with ACLs, but surface is a factor. I think surface is a factor, but also the amount of cycles, meaning you don't see these in the youngest players typically. They typically happen in more senior athletes. But definitely surface is a factor. But Achilles are game changers. Obviously we're seeing Aaron Rodgers try to return on a very aggressive timeline. And it's there's a lot of talk about that. And I don't know exactly what the surgical repair construct was, but the company that provided the implants for that surgical repair has discussed it a little bit in the public forum, and has said that he had a type of repair which includes what's called internal bracing, or large sutures being placed across the tendon and into the calcaneus or heel bone. And when that's the case, you may be seeing him returning so quickly because those large sutures are basically functioning as the tendon. So, and whether that's right or wrong, I don't think we have enough data, but it may be in part because of those large sutures that he's on this much faster timeline.
Interesting. I didn't know that.
Yeah.
Interesting. Doc, you're a busy guy. You are so beneficial to the community down here.
Thank you.
Are you doing any research right now? Lecturing, anything like that?
Yeah, during football season and basketball season, I'm a little bit light on the academics, but we try to do once a month some talks to physical therapy groups around town. We're always doing research that's kind of like in the background. We have a great group of research assistants at USC who are gathering data, writing papers, generating a kind of research on the day to day. So that's always happening in the background, and we're always working on improving our surgical techniques and improving our patient outcomes. So that's kind of constantly in the background for what we do. But kind of our lecturing happens at our national meetings, which are summertime, fortunately.
Gotcha. I lied. I got one more question.
Yeah.
You clearly love what you do. You're brilliant at it. You're a wealth of knowledge. What is your favorite part about being an orthopedic surgeon?
Honestly, it's the human interaction for me with patients. Like this morning, I got a text from the mom of a patient that I operated on in maybe 2017. And her name's Ariana Kova is the patient. She wouldn't mind me sharing it. And she was maybe 14 at the time, 14 or 15. And her mom texted me this morning. She got into medical school. So it's just really sweet to hear that, from mom that I was a positive influence, and that she's in large part doing what she's going to do for her life and her career because of the positive influence that I had on her. And that's kind of like on the grand scale, but honestly, the day-to-day interaction of seeing people get better, get back to the things they love to do, is what drives me to not only take great care of patients, but also do the academic stuff and try to advance our field, because there's lots of people you can affect that way.
Man, that story I had chills going down my spine. That's amazing. That's for me the same thing. That's what it's all about. I love that. Alex Weber, orthopedic surgeon. It's been an incredible talk with you, man. Thank you so much for making the time.
Thanks, Joey.
This is going to help a lot of people. So much information here to unpack, and also I think it's going to help a lot of folks. So we want to spread the good word, educate people. So I really appreciate you taking the time.
Thanks, Joey. It was great being here.
Great, man. All right. We will talk to you soon. Is there any way, how do people find you? Are you on social media? You got a website?
Yeah, website is probably best, alexwebermd.com.
That's with one B.
That's probably the best way. 1B. Yeah.
1B.
Thank you.
Amazing. Yeah. All right. Dr. Alex Weber, guys, it's been a pleasure. And Doc, we'll see you soon.
Thanks, Joey. Talk to you soon.